All right. Good morning, beautiful people. Beautiful people in the state. What are we doing today? Today's the day I revisit my story of Tumor. So, you know, just like in Dragon Ball Z, they always do a rehash of last time on Dragon Ball Z. We're gonna kind of do that for those that may have been joined in a little late. If you have not seen the part one, probably should watch that first. Well, what I'm doing here is I kind of want to talk a little bit about what it is like to suffer the rarest brain tumor one person can possibly get, as well as incredible complications that are mathematically impossible to survive. And yet, as I do believe I'm a real person, I have survived. And so I like to talk about that. A lot of the work that I do outside of my day job, which is being a software engineer and developer. Well, these days I seem to be doing more system administration work, but that's neither here nor there. Aside from that, all my personal endeavors, whether it be recently took up blacksmithing, jewelry crafting, doing a lot of art. All this beautiful art will be available on the website, right? Oh, there's my finger. There's the website, I think, somewhere around there. Yes. Anyways, it's kind of turned into a little bit of a family affair. The wifey, she's been working on a bunch of stuff too. She makes some really great like decal, like graphical stuff. So if you have a small business and you need like somebody to do some marketing, whether it be putting stuff on a tumbler, making stickers. Matter of fact, if you give me 1 second here, I will be able to pull up example. And they are really pretty good. She's gotten really good at this, and she has opened this up to something that she now sells. And so, to me, anytime you can take something that is digital and turn it into a physical representation, that is pretty amazing stuff. Wow, how far do I have to scroll? Why is it that every time I decide I want to look for something, I have to scroll my life away? All right, so let me zoom in here a little bit so you can kind of see that. So that's actually on her car. And then on the back of my truck, we got this. So yeah, she makes these. She can put them on a tumbler, t-shirt, hats, pretty much anywhere you could potentially want graphical representation. Again, for whether it be marketing for a small business. I mean, we even do a big business. I don't know how we manage that, but we would. Or just you want to put a logo somewhere for whatever reason. I mean, she makes a lot of meme sort of stuff, a lot of cultural reference stuff. I mean, it all seems to be a pretty big hit. So I'll get some backlinks up on the website that will drive you back over to her Etsy shop and her services. And of course, you can always reach out to me directly or reach out over the website. It has, you can make an account, you can send messages to me, all sorts of stuff over our website. Again, that's brain-stem.studio. But aside from that, the whole point is why is it all named brain? Brain this, brain that. Well, because my brain tumor, right? That's where it all stems from. To me, there's a certain irony in spending my life sort of realizing that I wasn't the typical person when it came down to my intellectual capabilities, and me quickly learning that that is my strength, right? I've never been a fast runner. I got I worked out in my 20s when I was in the Marine Corps, did law enforcement, things like that. And I was okay, I guess. I was never really, considering the work and effort I put into it, I was never really able to physically amount to much relative to the effort that I put in. The area where I've never had that issue was brain, right? Anything when it came down to brain power, that has always been somewhere where the coefficiency and ratio of effort to output has always been symmetrical in my favor to the result, which has been phenomenal and it's been great. that's one of the reasons why I got out of those careers and started going towards more IT and sort of leaning on my brain. So there was an irony when my brain decided to try to kill me. How does that even work from a personification standpoint? Is the brain you or not? That is a weird thing. It's interesting because going through some of this stuff, it has made me sit back and sort of think about the vehicle that is your body and how you ride in it. It is fascinating how we experience our life in the head, which is essentially you, right? You are sourced from the brain, and we experience life in the brain. And it's not even just from an eye standpoint. If you took somebody that was born blind, I guarantee they still have the sensation and the feeling of riding through life experience from the top, right? That's just, you don't feel like you're in the stomach, right? This is something that we don't really think too much about, but I think those are interesting things to think about. One of the reasons I do think about it is after my first surgery, I actually woke up and I found the nurses were walking in reverse on the walls. One thing they didn't tell me, so I had most of my surgeries were done here. I don't know how well that's showing up on camera. Um, so a good amount of my brain surgeries were done there, and so they make entry through the ear. So I'm deaf on this in this ear, completely obliterate all the vestibular, inner ear, middle ear structures to expose the tumor, which sits right at the base of the skull. At least in my case, it did. Pushing on my actual brainstem. I'll actually real quick show you a picture here. So this is going to be a little sneak peek of the docket for the VA thing. That one's big episode there. A lot of interesting things that I'm going to talk about. VA breaks the law. They injure and abuse veterans. They're a disgusting organization. And I will go into that in depth, but obviously I need to get through this first so you understand why I'm seeking care through the VA, and where do I actually give them authority over scope when it comes down to my healthcare. So there's a little sneak peek of what I'm kind of putting together. But here's the tumor, and you can see here, you can see that sort of this is what's known as midline shift, right? So your brain stem is supposed to go up and down. As we can see, in my case, it has been pushed over. This is not good. This is fatal. When you're here, you're not far from going under. What occurs and how this kills you is this cuts off the signals from the brain to the spine that tell your parasympathetic nervous system to continue to operate. Parasympathetic is the involuntary aspect of the central nervous system. It controls things such as breathing, coughing, heart rate, things that you don't have to think about. You don't have to tell yourself to do. You just do it. And so, obviously having things interfere with this is very scary. This is where you get, your heart arrhythmias that can be very scary, like Tortoise points, which is twisting the points, based upon EKG, patterns. You can see some twisting on there. And so that is a precursor for VFib, or ventricular fibrillation, or where the heart begins to quiver in the bottom part of the heart. When that happens, you usually lose consciousness within seconds and you're dead within minutes. So not a good place to be, but that's sort of how this works. It does interfere with breathing and heart rate. And for me, it was doing that. And it still kind of does. Still kind of messes with my breathing. More on that with the VA because that's part of the VA's nonsense. And of course, I can hear one of the cats screaming. We're representing the cats today. We have 10 inside, 2 outside. One of the outside ones is screaming. So if you hear it screaming, just feel free to ignore it. It's fine. It's not cold or anything out there. She's just being ridiculous and wants attention. Probably going through heat too. Nothing more agonizing than a stray cat in estrus. Anyways, so that's that. We'll talk more about that as time comes up, but that's what we're here to talk about. We're here to talk about kind of the second half and some of the things that So what I endured, things that I learned that I think are great information to share with the public, things that um, you don't want to learn the way that I learned, right? You'd like to know this stuff beforehand so you can understand what you're preparing for should you actually come across a big problem in life when it comes to your health. Um, so that's where we're at. That's what we're doing. So if you missed the first part, might be a good idea to swing by and check that out. That a lot of that was more focused on the diagnosis and the discovery of it. There was a lot of things about that process that unfortunately complicated this and made the prognosis for a positive outcome less likely. And had I known some of the things that I would learn later, I could have employed those as a part of my self advocacy plan, and maybe we wouldn't have ended up with as many complications and deficits and just various different bodily functions that were damaged. So, what I want to talk about this time is I want to kind of talk about uh, just what life was like after kind of my first surgery. So the first surgery was done in San Diego. Me and the wifey, we drove cross country from Florida at the time to San Diego. A lot of people were wondering why we chose to do that. That's just a preferential thing. I simply I have some mental issues around flying. When I was in Iraq, one of the planes I was on got shot at. They took evasive maneuvers. Fast forward to now, I just flying just doesn't really jive with me too well. Is what it is, not a big deal. Um, so, anyways, we drove there. That was fun, I guess. Not really. Um, and from there, we actually stayed, maybe 2 or 3 weeks. We stayed there now in San Diego, part of the University of California, obviously the San Diego branch. They have this place called the Jacobs Medical Center. That's where I had my surgery done. That's where the program that I went to is based out of. Now, the program there is head up by two gentlemen, head of neurosurgery, Dr. Schwartz, head of neuroenterology surgery, Dr. Friedman. And together they make, their acoustic neuroma program or vestibular schwannoma program out in San Diego. They are sort of the leading guys in this. They know it better than anyone else. Um, if you need acoustic neuroma and vestibular schwannoma surgery, these are probably the guys you want to be talking to for the most part. For me, it did not go well. The reason it didn't go well is because they're so good at what they do. Again, something I didn't realize at the time. From so in Western medicine, there's a philosophy, I guess, or mantra, whatever you might want to call it, where they say if you hear hooves, fake horse, right? Not zebra. So what are they saying there? Well, what they're saying there is that the approach and care plan architecture and sustainment should be done from the perspective of the most common possibility, right? The cause and effect model. Don't go off on crazy hunches, which is great until you are the zebra. So their plan is designed for the horses. The tip. So first off, if you end up with an acoustic neuroma, vestibular schwannoma, you already got one of the brain tumors there is. For me to reach the size of how big mine was without symptoms, even more strange. My symptoms were pretty low. Just mostly blood flow. I could hear that in my ear. Occasional dizziness. And sometimes I would lose hearing in that ear and it would hurt a little bit. But my primary care provider at the time through the VA was absolutely convinced for years that it was nothing more than an ear infection. Obviously was not. I had to kind of go through and do the workup to actually justify the MRI that I got, and that enabled me to not die. Again, more we'll talk about during the VA, but had it been for them, I'd be dead. So what I want to do is just bring this back up again so you can kind of again see how big we're talking here and where it sort of uh, starts from. So this right here, obviously, let's try a different color there. Let's do red. This right here is obviously the ear. And it's kind of hard to tell, but because it's, you see this like, oh, yeah, that's the brain. But the tumor actually starts right here. So so it actually starts here and it grows out and then it pushes over and causes the problem. These are generally benign tumors. Not in a good spot regardless, but they're generally pretty benign. Um, So regardless, very rare. What ends up occurring is you would have your neuroontology, which is like a crossover specialization between ENT and neuro. They're going to be the people that focus, kind of on this area. Maybe they're going to do a little work with eyes and maybe some throat, but obviously where it has more to do with your whatchamacallit, your way. What I want to do here, because I think this will make this a little easier, I'm going to switch my capture back over to my art tablet. And now what I'm going to do is I'm going to throw this over here. I'm going to look around and not be able to find my dang stylus, so this was probably a bad idea. Did it fall down? I don't know. I never can find my stylus. My robot. How unfortunate. 1 second. Let me go find it. All right, yeah, we're back. That actually ended up being quite useful. Not only did I find the stylus, but I also was able to shut the cats up because they were out of food. That often seems to be the case. They're either being murdered or they're starving because they've gone 5 minutes without food. That's bad. But all right. So as I was saying, imagine, if you will, this is your ear, right? Well, ear here. I'd say probably about here. So this is obviously a slice towards the back of the head. So we're missing kind of the front, but that's where a lot of these structures would be. So here's about where your cochlea would be. You'd have a nerve that would probably run like this, and it would be near a bunch of other nerves, right? And maybe even that's a nerve right there. Essentially, what you end up with is the cochlear nerve is a cranial nerve. It's going into your brain at a much higher level, right? Which is what's actually creepy about the cranial nerves is that if somebody is decapitated fast enough while there's still oxygenated blood in the head, they still have control over those cranial nerves in their conscious, which is why there has been cases where, because the guillotine was so effective at execution, where people would they'd pick up the head and the person would still be blinking, right? Or movement, a silent scream, because obviously you can't scream. Your voice box is gone, is still with the body. You're not there, but they can still control certain functions until obviously the oxygenated blood in their head dissipates. Normally, with those sort of injuries, it takes so long to get to that point that shock and trauma have already caused you to go unconscious. And so, that's that. But that's really creepy and scary thing to know, that you can still control a good amount of the cranial nerves and be conscious if the manner of the injury is effectively efficient enough. So anyways, this grows outwards like this. So what else I wanted to show you was when it comes to how they do this. So the team for neuroontology, they come in and they make entry through all the ear stuff, right? They're going to come in, they drill all this. This all gets destroyed. You can obviously see, well, it doesn't really matter because this is post-operatively. I had some other MRIs of post-operative, which I'll show you. I got one of my pseudomengenous fields, pretty wild looking. So anyways, they drill all this stuff out, they destroy it all, and then they get entry to the tumor and they begin to do what's called resection. This part here is done by neuroscience, by the neurosurgeons, the brain peoples, because you're so close to the brain at that point that now the actual brain surgeons have to take over. But entry, regardless how they do it, it oftentimes, if not always, is going to be done by the neurooncologist. There are a couple of different ways that they can go about doing this. Each offer their own proficiencies, their own drawbacks. It all depends. So one way they can do it is known as a mid fascia, which I want to say is about here. So they can make entry here to get to it, kind of top down, if you will. This one has a very high chance of saving your hearing, but it risks the other nerves, right? Because as you can see from what you're looking at, the surgeon is not going to see the facial nerve very well from this perspective. The one I had done, the translabyrinth that went through this section here, clean this up. So coming through this section here, translabyrinth, this being the labyrinth, trans, right, Gaussing, transnavigation, that has the best at preserving the facial nerve or the trigeminal nerve, the swallowing nerves, the nerves that, you really don't want to damage. Now, mine still ended up a little bit damaged, which is you can kind of see there's a little bit of asymmetry in my face. This side's weaker, but I also have some tightness from some additional surgeries that I had, and we'll talk about all that here in a moment. So the last one, they actually come from the behind. So they actually go behind the skull and they go around. So right about here, give or take, is the sigmoid node, which is the blood vessel that feeds the jugular vein. So they can go around it from the back. So quite literally, retro to go back, sigmoid. Retrosigmoid is the process. That's the official terminology for it. That one offers the best chance, from my understanding, to preserve hearing, and probably the riskiest when it comes down to preserving the nerve. So that's your biggest trade-off. With a tumor this large, as far as they're concerned, ain't much you can do about it. You're gonna lose your hearing. It's just too large not to. So the literature states that if that's the case, then what you want to do is now, since you can't save hearing, make your focus to save the nerves. So this is an important point, because when I first did my consult with Mayo Clinic, they wanted to do a retrosigmoid, and I didn't understand that, and I really pushed them on that, because I'd already read that, that is not recommended for a class 4 giant tumor. And at first they were kind of like, no, your case makes sense. I'm like, it really doesn't make sense. And eventually they ended up admitting to me that the Mayo Clinic neuroontology program operates with only retroid sigmoids in process, or in mindset, because they want to specialize in that. They want to be really good at that. Okay, sure, I get that. But at the same time, you're trying to force my case to fit this procedure rather than using a procedure that my case dictates. So that's something you need to be very careful about. If you have surgery and a doctor's telling you they're going to do a certain thing, make sure you understand the medical justification for it. Don't just accept it because they're the doctor, right? Nah, it's your head, it's your body. It's, you're the one getting the surgery done. You need to have a firm understanding of why they're doing it. And if they're just doing it because that's their policy, then you probably want to get a couple more opinions. Always get a second opinion anyways, no matter how well things go with the first one. And it doesn't hurt to get 3 or 4 opinions. I mean, again, this is your life. This is your body. Talk to as many people as you need to. So anyways, that's the deal there. So now the next thing I want to pull up is, so after my close this one. So after my first surgery, I spent about 2 weeks in San Diego. Probably about 5 or 6 days in the neuro ICU. The rest of it in bed rest till I could pretty much learn how to walk again, learn how to, have my head function correctly. Because again, they destroy all your balance structures on that side. So your brain needs time to kick over. So I'd say probably around day 11 or 12, we went in and we met with the doctors. They removed the stitches that I had at the time. I'm sure I have a picture of these stitches. I'm not quite sure where they're at. Oh, yeah, here we go. So this is obviously trigger warning. If you're someone that can't deal with seeing, surgical stuff, this is the point in which you probably don't want to watch anymore, because there will be pictures. Um, it's what I got. So this is going to be the first. Totally did that wrong. So this is going to be the first surgery and what the surgical site looked like. So obviously, this being the ear, it's still pretty bloody. You can kind of see that they just kind of cut in like that, and that's how they make their entry, right? Not a huge surgical site. The whole ear does come off, right? They do remove the whole ear. It gets pulled probably like this direction towards the face, and then they make their entry from there. Um, Obviously, my ear is not having a good day. It's not happy. It doesn't like what's going on. And I believe I should have a picture. Maybe I can find it. One second here. Where's my phone? Let me throw a picture, because I have all these on my phone, and so it'd probably be just easiest if I throw it on Discord to show some of these pictures. Let's do medical. Bloop, bloop, bloop. No, we don't want to be in there. Let's do general. Let's pop over here. So now here I was smart. And I would recommend organization with these sort of things, especially if you need to show people this sort of stuff. Now, for me, obviously, I knew I would, so I created an album that is specifically called Medical. And oh yeah, we got another one of my early MRIs. So here's all the initial surgery stuff. So what I'm going to do is we are going to, why is it not letting me share that? Select. Okay, there we go. And we're going to upload all that. And then what I'm going to do is I'm going to pop open Discord, and we'll just take a peek on Discord. Also, if you want to add me on Discord, feel free, open door. Never going to see me say no. All right. So here's some photos from then. Here's the top down. So this is a really good place to kind of get a look. So let me let's download down. And then I'll do save. Save. Pop back over here. Downloads. And then let's open you. Edit. It'd be nice if they let you do markup just on any screen. Should be a feature. Maybe it is. All right, so let's get markup. All right. So right there, that big chunky boy, that is the retroid or not retroid signal, but the actual sigmoid sinus. So that is the blood vessel that feeds the jugular. So the way that contrast MRIs work, if you're not familiar with it, the contrast itself is what illuminates, right? In an MRI. So obviously they administer that via IV. So everywhere that you have blood flow, that's what highlights. So obviously the brain does not have a lot of direct highlighting. Highlighting and color contrast is how they determine the type of tissue things are. So that's why the tumor stands out. To me, I was sort of shocked to see that it stood out so clearly. And the reason it does that is because it has a lot of blood flow. So obviously, it's picking up a lot of that dye. Um, but you can see that the other veins, right? So we obviously have some blood flow here and here, right? So you can kind of, and you can also see my deviated septum there. It's pretty bad. That was from child abuse. We'll talk about that. That I'll have to do an whole episode on my childhood abuse. Um, but you can see right here, these are supposed to both be symmetrical in size, but you can actually see that it's not. This one has been collapsed or pushed on. So that's the fourth and fifth ventricle. They are much like the rest of the ventricles in your brain, responsible for creating spinal fluid. When those are getting blocked like that, it will cause the higher parts on there to swell open, right? Because obviously they can't release their spinal fluid. Not good. You do not want those things getting enlarged. Mine were there. And then obviously there was just complete blockage, so it couldn't drain properly. So my brain was essentially expanding from the backside out. Not good. So this is to me one of the more fascinating things about this is, so again, this right here being the red, the sigmoid. Like I said, my symptoms or very few. One of the main ones I had was I could hear blood flow, right? And the reason I could hear blood flow is because this tumor, because it is pushed this backwards, obviously it can't, it hits the skull here. So what happens is it has to now kind of push these areas forward. So what happened is it moved this closer to me ear. And that is why I could hear blood flow. It's because I was hearing the actual sigmoid, right? Like I could actually hear it. I could hear my heartbeat. It was pretty wild. Um, so that's yeah. So this is a cool picture because of that. I think it's this is probably the first slice that I saw that really captured uh the sort of anatomical and physiological impacts that were being caused by it. So here you can see here, swollen face on the left side. That's where the surgery was done. They do this weird kind of bonnet dressing post-operatively. Um, but yep, so this would probably within the first day or two after the surgery. Again, here's a better look at the actual surgical site. You'll notice, and as these go on, it gets worse and worse. A lot of swelling in this area. Now, I was heavier back then. I've lost, oh gosh, maybe about 100 pounds since then. So, some of it's fat, but also a good amount of it was swelling. A lot of fluid builds up in these areas. But as you can see, not a massive scar. It really isn't. Um, I don't know. I think a lot of people think of brain surgery, they're popping the cap of your skull off and working on you from there, but not so much. Here's a picture of me and the wifey. So this was after I woke up sometime, clearly. As you can tell, I am not quite sure what's going on. Oh, man. She has a picture somewhere. I don't know where it's at. It's hilarious. It was, I guess, right when they woke me up, my eyes were bulging and I looked like I had seen some shit. Probably did. Pretty wild time. Anyways, that is that. So, I sat in San Diego for about 2 weeks. We got the clearance at some point to travel, to return home. So we began to drive home. And as we started driving home, I'd say probably the second day after we had left, we were on the road heading to Denver to see some colleagues. And what we had saw was, or at least she had noticed it, is that there was some pushing going on my ear. It looked like my ear was a little further out, and I didn't think too much about it. Figured it was swollen. But as time would go on, almost by the hour, it kept getting bigger and bigger and bigger. So then when we got home, it was massive by that point. It was awful. And we had been sending pictures and messages back to the surgical team saying, hey, something's not right here. What is going on? And they assured us that this is normal. Maybe it's a seroma, which is an accumulation of serum. So obviously, your blood can be broken down into a lot of different aspects. So sanguine fluid is blood, right? Sanguine's blood. Um, you have other things like serosanguine, which is like partial blood, or you can just have uh, um, serofluid, right? Which would be more just like serum of the blood. And so when you have an accumulation of blood, it's a hematoma, right? You have an accumulation of serosanguine fluid, then maybe it would be, I don't know what the hell they would call. I mean, usually it's an abscess, right? Um, but when you have an accumulation of just serofluid, then it's probably going to be a seroma. Um, Now, in my case, that's not what it was. My case is it ended up being what's called a pseudo-Minginus seal. A pseudo-Minginus seal, pseudo-false Minginus seal, Mingine brain seal, essentially an implication that this was a false brain ventricle, right? That my body was essentially created a new ventricle that was not supposed to be there. So that's where the term pseudo-Minginus seal comes from. And it started getting pretty bad. It continued to get larger and larger, excuse me, and larger until eventually, one night it ruptured, and that was a no good, a no good. And once it ruptured, so here's some early pictures. I'm just grabbing them now so we can kind of talk about it. So let me pull up this early picture. So this is what it started to look like. Pretty gross looking, right? It's starting to swell out. It's not too bad at this point. It would go on a lot worse. So after it had got as bad as it did, and it ruptured, now I have a spinal fluid leak. This is now a medical emergency. The idea is if spinal fluid can get out, bacteria can get in, right? Which is exactly what happened. I ended up getting bacterial meningitis, which is not, I mean, that's a very, very bad place to be. Bacterial meningitis, in my case, it ended up being two strains of staph, or no, two strains of strep. One was the strep that generally is found on skin, and another one that's found, usually in the mouth. And then a strain of staph, which I think that one was a dermal staph strain. So in both cases, probably, it ruptured while I was sleeping. I woke up to a wet pillow, and what had probably happened, maybe it mixed with some drool, as people drool, and then obviously it was picking up bacteria from the skin, and it all got in, right? And once that happens, you are in a bad place. You are in a very bad place. And this is what it was looking like by that point. You can just see how awful it had gotten. It hurt. You definitely don't have, a head looking like that and having a good day. Now, I do have a really, really cool picture. I think it's a cool picture of the actual MRI here. So let's take a look at that. But man, if that doesn't tell you what's going on, that is wild, right? Like you can just see. So that's why, so if we look, does this show up? Yeah. So if you look here, these are kind of the tail end of the upper ventricles. And as you can see, they're black as well because they're a cavity filled with fluid. Well, as you can see here, all this fluid was there, right? And that's not, you do not want that. So what you're seeing on this other picture here, right? This part right here, that's what you're seeing right here. What you're not seeing is the inner stuff, right? You maybe a little bit because obviously it's pushing this flesh out, but this right here is a very, very big problem. So what they end up doing with something like that is they have to relieve the pressure. So they end up positioning and inserting what's known as a lumbar drain, right? So it's a tube that goes into your spinal column. It's very painful to have placed. The way that they know they're in the right spot is based upon the type of pain you have. It's awful, right? Didn't matter. They gave me fentanyl and lidocaine. Didn't matter. Hurt like hell. 10 out of 10 on the pain scale. Do not recommend getting a lumbar drain placed. Again, different than a lumbar puncture. Lumbar puncture is they're just puncturing into that cavity to remove spinal fluid. In the case of a drain, they're actually placing a fairly large diameter catheter to drain off the excessive spinal fluid to the bring down the amount of fluid that's present in the body. The hope there is that by doing so, maybe that would deflate and everything would have a chance to heal. Spoiler alert, that did not happen. And the draining of the fluid was incredibly painful. Every time they drained it, it felt like razor blades running up and down my legs. It was awful, absolutely awful. And they would drain every hour. And this was one of the first points in which I started getting involved with it, because they didn't understand why was the pseudomyogenius seal not shrinking, right? That they were relieving the pressure and it was getting worse, and they didn't understand what was happening. And so I said, well, maybe you guys need to up it, right? Maybe 30 milliliters per hour wasn't enough. Let's try 50. So they went back and they had their surgical panel, and and the team of surgeons talk about it, and they took me up on it, and they came back and they started doing 50, and that worked for a while. For a few days, the pseudomyogenius seal collapsed, and I was like, great, we're looking good, we're doing things here. Unfortunately, it would not remain that way. It would continue to get worse. So at some point, they then decided, okay, well, we have to do something about this. The first thing they needed to do was figure out what was happening in the surgical site, because I have a brain infection. Things are happening. Like, it doesn't look like my markers are going down. I seem to be getting worse. So they need to do an exploratory surgery and what they call a washout. So washout, in this particular case meant they were going back into the area. They were removing any of the dead crap and removing all the surgical hardware and just cleaning and sterilizing the area, which they did. They removed the titanium that was placed. And I had talked to one of the surgeons, and he had told me, well, when we got in there, so they take a fat graft from your stomach, and they place it in there. They pack it in there with things like bone wax and, these different types of pastes and cements that are supposed to kind of turn into like a sort of false bone-like structure and to help seal the area. And what's supposed to occur is the fat graft is then supposed to seek and receive blood flow. That didn't happen in my case. That's one of the reasons it ruptured. There was no blood flow. The fat tissue would end up dying and turning necrotic. And so obviously that was not good, right? Having decaying fat inside your skull was not good. This was causing a lot of problems. So they removed it, and then they closed it all back up. They did, the exact same process again. They removed more fat, closed it all up. I know, unfortunately, and this is a picture of it after the washout. So this would have been after the second major surgery. As you can see, not looking so good, right? You can see the fresh graphene that they put in, that sort of synthetic skin that they sort of seal it up with. They weren't just going to leave it with just the sutures this time. But as you can see, it's pretty angry, right? The skin is inflamed because of all that surface tension. So that's why it's red like that. We got some other pictures here to get another angle. And you kind of see from there, right? So I can see some of the swelling had gone down, though, in my neck, right? It's not as bad looking. It gets a lot worse. We'll get there, though. We'll get there. Let's see what else we got here. Here's a good one. This one just has a little bit better lighting, so you can just see how not fun that is. Yeah. So at this point, I can see up here that there is some dressing towards the top. I don't know if you can see that, but right along here, there's some dressing. So at this point, Because this issue kept occurring, what they did is they moved from a lumbar drain to what they call an emergency EVD, or an external ventricular drain. Now, this was a pretty wild experience because they essentially gave me some lidocaine and gave me something called Versed, and the idea was they wanted to make me no anxiety and just chill as a cucumber. The belief is that they were going to give me something, maybe propofol, I don't know, but I was not going to remember anything. Turns out I remember all of it, right? And so understand that sometimes they're going to tell you things based upon their understanding of how the medication is supposed to work. Does not mean it's going to work for you. So for me, did not work. I remembered everything. And what they did is they came up about here and they had a crank drill and they drilled a hole slowly through my head with this crank drill. Now they couldn't use, one of those air burr drills because, there's not much room. I don't know if one of those earlier pictures might show it. Nah, maybe the other MRI. But anyways, if you can sort of recall, there's not much tissue between the top part of the head and the brain. Let me see. Let me see if I can find that picture I was showing. Yeah, this works. All right, so let me pop this over here. So if you look, you can see you don't really have a whole lot of room, right? It's just right there. So essentially imagine, right, they're right here and they're just going to slowly drill and they just want to stop just there. See if I can zoom in a little bit, make this a little bit clear as to what they were trying to accomplish. So you can actually see this layer right here. That's your meninge, right? That's the thing that covers your head. A lot of people have heard of subdermal hematomas. The dura mater and the meninges, that's this stuff right here. So when you have a subdermal hematoma, that means you have a bruising like down here, right? Your meninges cover the brain. That's where meningitis comes from. So what they wanted to do is they wanted to just barely get in there, and then they insert a tube, and that tube runs down, and they have to, I'm assuming, use a scope to sort of guide it. And what they're trying to do is they're trying to guide it back into your ventricle. And from there, that becomes the new drain, right? So now they're trying to drain off the excessive spinal fluid and pressure from that. And what I'm doing right now is I'm pulling up a picture of that. I got a few that we can kind of look at so you can see what that looks like. Again, pretty wild experience to be remembering all this. They told me I wouldn't, but I did. And so just uploaded those. They're from the load. All right. So here you can see that's the tube going in. This right here, trying to remember what they do here, because obviously I have quite a few staples there. I think that was potentially the scope that they used. It was just obviously another entry point. This actually would go all the way back to here. Actually, I think this might be the entry point, because what I feel here on that scar there, it's indented. So it almost feels like maybe that is where they drilled. Because one thing that they'll do is they'll feed things like sort of threaded through like a string through a needle. And so it's possible that this tube actually runs all the way here, and just this part they keep under. Because it is incredibly important to keep this area sterile, right? If not, you're probably just going to kill your patient. Especially when I'm already dealing with, meningitis. So, as you can see, they have this big plastic thing on there, runs all the way back. This comes out, runs down, and that allows them to drain off the fluid. Now, they would end up doing it again on the other side to do kind of the same thing. Now, what's interesting is this pipe here that's on my head, well, it's showing up. This is doing the same thing that those external drains do, right? That is a ventral peritoneal shunt. So in that case, the tube, instead of it being external like you see here, it runs back across my neck, down my stomach, or over my breastplate, down into my stomach. And it does the same thing. It's removing spinal fluid, keeping the pressure down. And sending it to the peritoneal, because the peritoneal is highly vasculated, meaning it has a lot of blood vessels, which allows it to reabsorb the spinal fluid, because that's how your body circulates it, right? Your brain creates it, it gets pooped out into your body usually through the spinal column, where it's reabsorbed. If you can't, and you develop hydrocephalus, which is, excessive spinal fluid pressure, too much spinal fluid, like I did, that's obviously a medical emergency. So what's interesting about that is your spinal fluid's viscosity, or how thick it is based upon your hydration level. So if you watch MMA at all, and you watch UFC fighters, they're always dehydrating themselves before a fight. Well, if they know anything about anatomy and physiology, they would actually learn that that's messing with the viscosity of the spinal fluid, and the spinal fluid is your shock absorber. It's supposed to, if you get hit, your brain is floating like a brain in a jar, but your head is the jar. It's floating in the spinal fluid, and it's being kept held up. Again, if we were to look at, it's kind of hard to tell, but if you, all these black spots that you see running, along here, this is all spinal fluid, and the brain is just kind of floating there, right? It's almost like those air ride trailers. It's just slightly above it, right? It's not actually fully making contact. There might be that, obviously there are places where there's contact. I mean, you can kind of see there on these parts, it's resting. So obviously the weight is pushing down. And then obviously your spinal column and brainstem are, point in which they touch and meet. Otherwise, that's what an internal decapitation is, right? Severing the brainstem from the spinal column. That's what a decapitation is attempting to do. So anyways, yeah, that's what happens. And so when you're dehydrated, that fluid becomes more viscous and sort of jelly-like, and it loses its ability to dissipate energy, which is why people that dehydrate very hard in professional combat sports and boxing tend to get knocked out easier. There's a reason for that. The body does compensate and adjusts the viscosity of the spinal fluid. So that's that. I do have a meeting coming up, and this one again is gonna run long. I mean, these are long. It's gonna take a while for me to get through all this, but we'll get there. So I'm gonna go ahead and wrap that up here. So we know we're kind of stopping at the first EVD placement. The bigger surgeries are to come. We'll talk about those here in a moment, maybe tomorrow or something. But those surgeries are much larger, far more radical and invasive. They're a treat. They're interested, that's for sure. But if you made it this long, once again, I do appreciate you hanging out, and I will see you on the next one.